A very good evening to everyone, and all my regards and respect to senior members, chairpersons, speakers, and president. We are going to start a very informative CME on gastroenterology, and we have wonderful speaker. Dr. Shubhra is young and dynamic, and Dr. A.C. Agrawal sir, we all know, he is full of knowledge and always guiding us. So at the start, I would like to present the presidential caller to President Dr. Anurag Malhotra. I would request President to allow us to start the meeting.
I call the meeting to order.
Thank you, sir.
Good evening, everybody. Dr. A.C. Agrawal, sir. My Honorary Secretary. Our Speaker, Dr. Shubhra Mishra. And all the officials sitting on the dais. This is a CME which has been asked from the National IEMA. National IEMA, Mr. Lele just called up and said we have to conduct this CME on behalf of National IEMA. So this was planned 1 month back, and we got a date just after the installation, and we are going to conduct this CME on gastro. And we are thankful to Dr. Shubhra Mishra and Dr. A.C. Agrawal sir, who have just agreed to be our speaker in such a short notice. And we request to start the CME. I hand over the mic to my Honorary Secretary, Dr. Sharmi.
Thank you, sir. The moderator of today's program, we all know him. He has been working so hard in 24-25 and took the IMA to new heights. Secretary, past Secretary, Dr. Vikas Mishra. Secretary कहने की आदत पड़ गई है. So I would request Dr. Vikas Mishra to kindly moderate the session.
Thank you so much, Dr. Shalini ma'am, Honorary Secretary IMA Kanpur branch. Since the protocol has already been completed, so without wasting much time, as we all know, Dr. A.C. Agrawal sir and Shubhra both are renowned doctors of Kanpur, so they need no introduction. May I request my first speaker, Dr. Shubhra Mishra. She happens to be MD DM gastroenterologist, Gastro Liver Hospital Kanpur, to kindly start her presentation.
Good evening, everybody. At the outset, I would like to thank IMA Kanpur and Pfizer for inviting me for this academic event. So what I'll be talking about is age-linked shifts in GI physiology. What are the implications for diagnosis and treatment? So the initial part will be about, these are my disclaimers from Pfizer. So the initial part will be about what are the age-linked changes which occur in the GI tract. Then we'll just talk briefly about a few medicines which are used in GERD dyspepsia and what can be the changes which we do like in our prescriptions as our patients age. So as we know that the prevalence of GI disorders is quite high, and as we can see that up to 8.85 million people globally have some GI related comorbidity. And if we talk about India, then at least 18% of people, of older people more than 45 years of age, tend to have some GI complaint. Of this, upper GI complaints are seen more commonly in women, whereas lower GI complaints are seen more commonly in men. And as we know, in patients who have other comorbidities or other psychosocial illnesses, they'll tend to have more of GI complaints as well. So what are the age-dependent changes in GI physiology? If we look at our immune system, so when a child is at the infancy or in the young childhood stage, that time their immune system is just developing, and they are developing immune tolerance to certain agents, and they are developing immunity to certain agents. And then once they come into adolescence or adulthood, then they reach a homeostasis. And then once a patient becomes an elderly, as the age increases, there is a change in immunity such that the innate immunity starts declining. There is a decrease in gastric and colonic motility. There will be a change in the gut microbiota, and there will be a change in dietary pattern as well as in nutrient absorption as well. So the changes in the GI system are actually dependent on other systems as well. So if a patient has a neurological impairment, that can lead to changes in the GI system. So there can be impaired cognitive functioning, decreased swallowing, decrease in esophageal and gastric motility. There can be metabolic changes. So a patient who has diabetes, because of insulin resistance, there will be a change in the gut microbiota, and there will be a change in gut motility as well. Similarly, it depends on what drugs any person is taking. If there are a lot of drugs being taken, then that can lead to mucosal injury, decreased motility, change in the gut microbiome. And ultimately, with age, there comes a decrease in appetite, which leads to, and a decreased mobility, which leads to change in the gut functioning as well. So why do our defenses decline with aging? The decline is threefold. One is your structural changes. There can be atrophy of the villi, there can be atrophy of the gut mucosa. There's a decrease in function. So there's a decrease in parietal cell mass, there's a decrease in gastric blood flow. And ultimately, because of a decrease in your innate immunity, there's an increased susceptibility to infections and increased susceptibility to injuries. So now looking at what are the age-related changes which occur, we'll go one by one, first esophagus, then stomach, and then the bowel. So this term, press by esophagus, was coined in 1964 to denote the changes which occur in an elderly patients as once they age. So basically, with age, the peristaltic movement of the esophagus decreases. There may be a decrease in motility of the upper esophageal sphincter, decreased pressures of the lower esophageal sphincters, and decrease in secondary peristalsis as well. All this can lead to motility disorders. Then there is decreased epithelial regeneration, which can lead to an increased susceptibility to injury and lead to increased incidence of GERD. And because of visceral hypersensitivity and psychocognitive hypervigilance, there will be an increased incidence of disorders of gut-brain dysfunction. And as we know, with increasing age, there is increase of certain structural disorders like hiatus hernia and Zenker's diverticulum, which are found more commonly in the elderly. Now, a lot of drugs also lead to esophageal dysfunction. So we can see there are a lot of drugs which will affect the esophageal mucosa, like NSAIDs, iron sulfate formulations, steroids, antibiotics. All these can lead to esophageal injury, and many antibiotics are known to cause pill-induced esophagitis. Similarly, there are many other drugs which can lead to a decrease in LES pressure, like calcium channel blockers, theophylline, nitrous derivatives. This can lead to more reflux. Now, what about the stomach? So, as the age increases, changes in the stomach can occur because of cellular senescence, that is aging, because of inflammation, because of environmental factors like changes in diet, presence of H. pylori infection, and use of other medicines. So, if there is mucosal atrophy, there will be a decreased parietal cell mass, decrease in acid synthesis, decrease in intrinsic factor synthesis, which can also lead to a decrease in B12 levels. If there is an impaired motility, which can again be because of decrease in activity of interstitial cells of Kajal and decreased vagal activity, there will be gastroparesis. Then we know that mucosal defenses are low because of decrease in mucin secretion and bicarbonate secretion. And finally, because of decreased mucosal blood flow, there will be a impaired regeneration, which can lead to an increased tendency of erosion, ulcer formation, and GI bleed. Now, important thing to know in elderly is that their symptoms may not always be typical. So they might not have typical postprandial fullness and epigastric pain. It might be just a weight pain, nausea, anorexia, weight loss. So anyway, what our recommendations say that any patient more than 45 years of age, even if they don't have alarm symptoms, even if they have just non-specific dyspeptic symptoms, they should undergo an endoscopy to look for any gastric injury. And many of these patients, especially in the elderly, because they do not have many specific symptoms, they do not present early, many times the first presentation is GI bleed. So we should not ignore even vague symptoms in elderly patients. Now, what about changes in the intestines? So when we talk about the small intestine, in the small intestine changes can be structural. There will be increased incidence of villus atrophy. There will be increased incidence of decrease in microvascular network, which can lead to malabsorption. Then there is a change in the gut microbiota, and there is phenomena which is called leaky gut. Leaky gut means that the permeability of the mucosa increases, because of which more pro-inflammatory cytokines come into the gut, and which leads to more malabsorption and more tendency for GI infections as compared to a younger population. Now what about the colon? In the colon, changes can occur, one, to the motility. So there will be decrease in strength and frequency of contractions. There can be a decrease in sensitivity of the rectum. So the patient might not know that okay, the stool has reached the rectum, because of which there is an increased incidence of fecal impaction and subsequent spurious diarrhea or fecal incontinence. And thirdly, because of a reduction in goblet cells, there is decrease in mucus formation, which leads to more friction in the colon, and this leads to more formation of stercoral ulcers and more presentation with just a discomfort in the rectum area, which is there because of decreased mucin secretion. Now all these changes can occur because of aging, but they are also precipitated by other factors. So because there is decreased mobility in elderly, this leads to further decrease in motility of the colon as well. Because there is malnutrition and decreased overall appetite, this also leads to further decrease in motility of the colon. So broadly speaking, the GI disorders in older adults include esophagitis, GERD, H. pylori infections, gastric cancers, hiatal hernias. Your small bowel disorders include mesenteric ischemia and SIBO. Your large bowel disorders include diverticular disease, microscopic colitis, very important. So microscopic colitis tends to present mainly in elderly patients. It will present with painless diarrhea, and you might confuse it with IBS-D because there are not many changes on endoscopy, colonoscopy, but your history will know that this is microscopic colitis. So a short-term history, watery diarrhea, elderly patient, history of some recent change in drug intake, we should suspect microscopic colitis. Drug-induced diarrhea is also very common, and ultimately any elderly patient, we should always be on a lookout for malignancies. So just a slide kind of summarizing all these changes which occur in patients with in elderly patients. So there is decrease in saliva secretion, there is a change in pressures of the esophagus, there is a change in motility, there is dysbiosis, and all this leads to increase in other pathologies including SIBO, including diverticulosis, including constipation, incontinence. Now ultimately our GI tract exists in our body as a part of the whole, so other diseases will lead to changes in the GI tract. So if a person is obese, they'll have a higher incidence of GERD, gallstones, GI cancers. If a patient is diabetic, they'll have insulin resistance, which can lead to dysbiosis, which can lead to gastroparesis, which can lead to constipation. Patients with neurological disorders, they tend to have a poor appetite, they'll have cyalorrhea, they'll have dysphagia, they'll have gastroparesis, and ultimately immunocompromised patients. So diabetics, CKDs, patients who have previously had radiation or chemotherapy, all these patients are at a risk for other GI infections, opportunistic infections as well. So we cannot reverse aging, we cannot even stop aging, but we can do some changes in the lifestyle so that the impact of aging is low. And these preventive strategies is basically your diet and lifestyle changes. So promoting a healthy diet rich in fibers, rich foods, and low in unsaturated fatty acids, encouraging physical activity, encouraging sleep. Somehow in India with time, although now people are aware of cardio exercise which is needed, so people are going for walks, people are going for cycling, but somehow the uptake of resistance training is still very low in the elderly population. So that is something which has to be explained. So when we do these changes in our lifestyle, it leads to a more healthy gut microbiota, it leads to an improvement in gut motility, and it leads to an improvement in digestion and overall well-being. So how do we assess any patient? So general, what we all do in our clinical practice, we look at the history, we look at the physical examination. Now this IFEED score actually is used by the surgeons for post-operative GI function, that whether the patient is recovering well or not. So I feed stands for I is intake, F is whether the patient is feeling nauseated, E is emesis, second E is examination, and D is duration of symptoms. So it kind of just tells you about that what is the patient's gut recovering well, because if the patient's gut is recovering well, they have a good gastric motility, they will feel hungry on themselves, they will not have nausea, they would want to take some food. And ultimately when we start investigating patients, so then we can go for endoscopy, colonoscopy, radiological imaging. Certain breath tests can also be done, like hydrogen breath test can be done for SIBO, a stool DNA testing can be done to look for screening for colon cancer, and serological tests can be done to look for other diseases like thyroid, diabetes, or even for chronic gastric atrophy. Now looking at some lifestyle modifications, so this is now mainly for GERD and dyspepsia. So when we say that patients should go for regular exercise, obese patients should try to lose weight, we should have small frequent meals, avoid foods which cause reflux, avoid smoking, avoid alcohol. This is basically your diet and lifestyle changes to prevent GERD so that the need for medications decrease. And if you look at the medicines which are used for GI disorders, we all know these: antacids, PPIs, antiemetics, laxative. What is not written here is your potassium channel acid blockers, which are now freely available in the market. And though they have very good potency in suppressing acids, they are also obviously not without their own side effects, and we'll be talking about them soon. So when we talk about management of patients who are geriatric, the 5 M's are there which have to be kept in mind, which is first the mind itself. What is the mentation of the patient? Is the patient depressed? Is the patient altered? What is the mobility? What is the gait? Is there a risk for falls? Is the patient frail or not? What are the medications the patient is on? Ultimately, every doctor should aim for that the patient is able to reach their optimal levels in the minimum medicines possible and with minimal interactions between the medicines. And ultimately, all disorders have interactions with each other, and we should treat any patient as a whole rather than treating just one system, and they should meet their own individual goals. So polypharmacy is an important issue in elderly because they are usually on multiple drugs for multiple medicines. So if we talk about GERD, in GERD we have usually 3 kinds of drugs which are being used: something to suppress acid secretion, something which will act as a prokinetic agent, and ultimately something which is used on SOS basis like an antacid. And fourthly, ultimately, if a patient has functional heartburn, then maybe a neuromodulator will also be there in the patient's prescription. So we have to try and reduce the number of medicines which a patient is using. Now these side effects which are written, so if we see, these are actually not very common. So with PPI, headache, rash, dizziness, these are all kind of rare side effects reported in 1 or 2 case reports. What is actually proven is that there's an increased risk of GI infections with long-term PPI. There's an increased risk of chronic eosinophilic tubulointerstitial nephritis with PPI, and there's an increased risk of osteoporosis and B12 deficiency with increased use of PPI. So PPI should anyways be avoided in patients who are CKD, and we should aim to tailor the therapy so that we can decrease the dose as soon as possible. So ideally speaking, if a patient has been given PPI for, let's say, GERD, we should try that for 8 weeks you give continuous therapy, and after that you start tapering off PPIs for these patients. Now, who are the patients in whom you cannot taper PPIs off or who need continuous therapy? So patients who have severe erosive esophagitis, patients who have Barrett's esophagus, patients who need to be on some other drug which will cause gastric injury. So let's say a patient is a known case of CAD who has to be on aspirin, has to be on clopidogrel, and he also has a previous history of GI bleed. In such a patient, you would not want to taper off their PPI or potassium channel blocker, whatever they are using. And similarly, suppose that there is a patient with eosinophilic esophagitis. So these are not the patients in whom you would want to stop the drugs. These are the patients in whom you would want to continue drugs for a long term. In rest of the patients who have non-erosive reflux disease, patients who have functional dyspepsia, patients who have H. pylori gastritis and you have treated H. pylori, these are the patients in which you would want to taper off your PPIs or potassium channel acid inhibitors. Now, how to do that? So what data says is that once you decide that right now there is no indication to continue PPI anymore, you can actually stop PPIs abruptly. So it doesn't matter whether you do a slow taper or whether you do an abrupt stop. The risk of rebound hypersecretion will be there. Patients will tend to have some symptoms in the next 2 months, and for that you can give them on-demand therapy. You can give them some antacids, you can give them some H2 receptor antagonists, and after 2 months the patient will gradually stop having that acid hypersecretion and they will be able to remain off PPIs. So that is how we can stop PPIs, only when it is actually not indicated. So what is the role of antacids? Antacids are very good drugs. For one, they have a fast onset of action, they lead to an instant relief, and secondly, they have a good side effect profile. That means they do not have many side effects. So just looking at some of the antacids which are commonly available, we all know these: aluminum hydroxide, calcium carbonate, calcium hydroxide. What is not mentioned here is your sodium alginate, which is now very freely available in the market. The only precautions which we need to know is that we should avoid magnesium containing antacids in patients with CKD and patients who have risk of cardiac disease or have a history of CHF. And similarly, we should avoid aluminum containing antacids in patients who have CKD. Now, about sodium alginate. So once or twice I was asked that, but this is sodium alginate, will it lead to an exacerbation of hypertension? So it's actually reverse. Sodium alginate has been shown to form a biofilm on the villi, small intestinal villi, and it improves hypertension, at least in animal studies. So no, giving a sodium alginate containing RAF will not cause exacerbation of hypertension. Now there are also antacids with an anesthetic agent along with the antacid molecule. So like aluminum hydroxide with magnesium hydroxide and oxytocin. So this is an agent which will have an antacid property and a pain relieving property. Yes. So this will lead to instant pain relief. There will be a lower dose requirement and there will be minimum side effects. Now there have been multiple cohort studies in which they have shown that when we use a combination of antacid with anesthetic agent, it leads to a lower dose requirement and faster relief compared to antacid only in both ulcer disease as well as GERD. So I would say that your antacids are best used when you do not want to give prolonged PPI or potassium channel acid blockers. You are trying to wean the patient off those drugs. Second, when you have some specific contraindication like a patient with CKD where you do not want to give PPI for a longer period of time. Patients with functional dyspepsia, non-erosive reflux disease are the ones who will probably benefit more as compared to somebody with an erosive esophagitis. So just to summarize, aging impacts your GI motility, secretion, absorption and mucosal defense. There will be a change in gut microbiome with age. Our gut microbiome becomes less diverse and more labile with age, which leads to an increased tendency for infections. And this leads to, it leads to a change in our immune system as well as metabolic functions. There are non-pharmacological strategies to improve quality of life. Anesthetic antacids can be used for mucosal relief in acid-related symptoms. And ultimately, therapy for any patient should be targeted to whatever their problems are. And it's not one therapy for all. Thank you.
Thank you so much, Dr. Subhra, for such a wonderful presentation on age-related gastrointestinal changes, management and diagnosis. Your knowledge, confidence in presentation and aura seems to be the mirror replica of respected Dr. B.K. Mishra sir, who happens to be the best gastroenterologist not only of Kanpur city but the state and nation. Thank you so much. Please take your seat. And may I now request the House to please welcome our second eminent speaker, respected Dr. A.C. Agrawal sir, who will be speaking on GERD. Please sir.
And after Dr. Subhra has given such a wonderful talk, I don't know what is left behind for me to speak. And she has made my work easy as well as difficult. So bridging symptoms and systems. She has told us about, Dr. Shubhra has told us about the changes our GIT has with aging. And now what are the symptoms which arise and how as a doctor, as a physician, we bridge the gap between the symptoms and the treatment so that the patient is able to take treatment as advised. Because GIT problems, GIT complaints are very common in everybody of us. Most of the patients have some GIT problem. And if you ask 4 or 5 questions to any patient, पेट में दर्द होता है, गैस होता है, पॉटी होता है, तो हर जना कहेगा नींद आता है, तो हर जना उसमें पॉजिटिव रिस्पॉन्स होता है. So GIT symptoms are so prominent in every patient, and because of the availability of the OTC drugs, these PPIs which we say taper करो, ये करो, वो करो, ये सब theoretical चीज़ है. हमारे जो environment में PPIs वगैरह इतना commonly available है, everybody who is taking say any PPI with domperidone, they are taking it even once daily, twice daily for months or years together. So what we prescribe and what patient takes, that is sometimes it is very difficult to control. So now let us see. The high burden, there is a very high burden. This is what I just told you, that there is a high burden of the upper gastrointestinal disease symptoms, and GERD is the most important presenting features in most of the times. Gastroesophageal reflux disease, this is a clinical diagnosis. Most of the time it is a clinical diagnosis because of the reflux, and all those patients who present with reflux, they don't necessarily have to have a increased acid secretions. It is the same acid which is being secreted may be normal except for ZD syndrome, like those patients who have prolific amount of acid secretions. These patients have reflux because the lower esophageal sphincter becomes incompetent, it becomes relaxed. It is not able to close, and the normal acid secretion in the stomach is not meant for the esophagus. Except for occasional when you have a belching, there is the acid reflux which may come into your oral cavity, and then it is sent back to the place from where it has come by the esophageal peristaltic movements, and whatever acid comes in your oral cavity, so we have salivation and that has bicarbonate and that neutralizes it. So normally we don't have a feeling of कि हमको बर्निंग हो रहा है, ये हो रहा है, वो मोमेंट्री होता है. और GERD में वही सेम चीज, that is persistent, that recurs, and the symptoms are prominent and lasting. And then if you can find out a cause, or you are not able to find cause, there are functional dyspepsias and the peptic ulcer. These are the 3 variety of presentations in our patient. And there is a regional variations in upper GI symptoms in India. This was a large study, more than 10,000 patients, diabetic and non-diabetic patients, predominantly diabetic. And you see north, south, east, west, the patients have similar symptoms but different presentations. Similar disease but different presentation. Abdominal pain is more common in our North India, whereas in South India, bloating is more common. The reflux is there. Postprandial fullness. So epigastric pain, West India. This is because of the regional differences in the type of food intake. The type of masalas and condiments and the fermented foods in the south with all that idli, dosa and everything. So they have more of belching, bloating. So we have to understand what the patient wants to say actually. Interpretation of a proper history is very important because that will in itself say whether this is a functional or organic problem, many a times. So what are the risk factors? Upper GIT disorders with risk factors, as Dr. Shubhra has already told, low physical activity. Why low physical activity causes GIT symptoms? Because you have obesity, inactivity, and there is more acid secretion. You are lazy, you have feeling of depression, lying down, eating more, tummy is full, and then more of reflux. If there is a family history of GIT cancer or GIT problem, then naturally they have more symptom possibility. Old age, again, the secretions are reduced. That is why there is less of salivation, less of bicarbonate, less of the pepsin, and more of even the acid secretion is sometimes reduced, but obesity and laziness in old age, not inability to do the proper work, that causes upper GI disorders. High consumption of sweets and desserts, that increases acid secretions in your stomach if you take more of desserts and sweets. Low fiber consumption, females generally they may not like it, they eat slightly more than what the men like because they don't want to waste any food. They say whatever is left, we have made it with great efforts and we don't want to waste it, so they eat it many times. As the last part of the day, they eat about the remaining food sometimes in our families. So that is why they take meals last and they take meal which is more full. That is why probably, and because of the hormonal effects, also they have more upper GI distress now. Low BMI patients, even if those patients who are not mentally well, they eat less and then there is more of catabolic activities and there is more of acidity. And low BMI patients may be harboring some malignancy or some GI ulcer that may cause a low weight. Helicobacter infection, this is a very common cause presenting with in the patient with the duodenal ulcer patients. As far as the GERD is concerned, Helicobacter pylori patients who are being treated, they have less chances of the reflux into the stomach. Use of aspirin and non-steroidal agents, visceral fat and central obesity, they increase the intra-abdominal pressure and there is more reflux. Depression, alcohol and smoking, all these are the factors which increase the chances of you having upper GI problems. Delayed gastric emptying, postprandial fullness, vomiting, delayed proximal gastric emptying because of the stomach movements are dysrhythmic. So there is heartburn, regurgitation. Proximal gastric emptying is delayed, then more chances of reflux into the lower part of the esophagus. And there are early satiety, weight loss, abdominal pain, belching. These all are the symptoms because of the. Now, alarm features. This is very important. Alarm features in patients with the upper GI symptom diseases. Unintentional weight loss. See, if you are losing weight or you are reducing weight, these are the two symptoms. Whether you have to ask your patient, are you losing weight or are you reducing weight voluntarily or you are losing weight. And any significant weight loss is very important, especially in elderly patients. Elderly patients, there is a very important thing that the patient has to see his weight regularly. Dysphagia and odynophagia. Dysphagia is difficulty in swallowing and odynophagia is painful deglutition. So that may be because of some local problems or there may be some growth or some ulceration or something causing painful deglutition. Bleeding or anemia. Upper GI bleeding is a very important cause of any undiagnosed anemia in elderly patients because they don't bother about the color of the stool, which may be even tarry or black, and once you see what you are presenting with a severe anemia 4-5 grams and then you investigate and then you find that there is some ulcer or some cause of the bleeding in the GIT. Hematomesis, once they have massive hematomesis, only then you can have hematomesis because of the variceal bleeding or even ulcers. Black or bloody stool I have told you. Now let us see how do we proceed. History and examination is the most important part. You ask the patient history and exclude non-GIT origin. Exclude non-GI origin. I will tell you about the functional dyspepsia and the organic causes in the next slide. So you have to exclude non-GI origin. Predominant symptoms. What are the predominant symptoms? Epigastric pain, epigastric burning, postprandial fullness, early satiety, bloating, nausea and belching. These are signs of the functional dyspepsia. And if there is a recurrent heartburn and regurgitation, chest pain, esophagitis, peptic strictures, Barrett's esophagus, and atypical symptoms, asthma, hoarseness. See, once there is a GERD, a part of the acid may reach up to the throat and the patient may have constant dry hectic cough. And this is not very uncommon presentation. This is very commonly seen. The patients who are not responding, dry hectic cough, and they are having hoarseness of the voice. So this may be because of the vasovagal reflux also and direct reflux also in the throat. So sinusitis, upper respiratory problems may be because of the GERD. And then epigastric pain, burning, postprandial fullness. There may be a peptic ulcer disease. So most important thing is that you have to look for what you want to see in that patient. And investigations, because the gastroenterologist will be focusing their investigations basically on endoscopy, the first line, upper GI endoscopy, colonoscopy. But we as physicians first see that, have a good clinical examination that may really help to define whether the patient, how to proceed in this particular patients. Does the patient need testing for H. pylori, or whether the endoscopy is an essential part of the treatment or management. Upper GIT endoscopy, especially we have red flag signs and the patient is elderly. And we have red flag signs and elderly patient, then upper GI endoscopy, colonoscopy, they are very important investigations which may lead to a final diagnosis. Now organic means once we are able to find a cause for the symptoms, whether it is peptic ulcer, GERD, esophageal and gastric cancer, biliary and pancreatic disorders. See, we all constantly give treatment for acids. It is not always acid. It may be secretion from this other digestive enzymes. Even the bile is a very important cause of the lower esophageal irritation and esophagitis. Systemic and infectious diseases, they may also cause some organic cause. Now functional means once we are not able to find any identified cause. This is very important cause because this is the most common cause, non-identifiable cause. If we try to look for a cause and we are not able to find a cause, then there can be a dysrhythmia of the stomach movements, peristaltic waves, and there may be reflux. Now let us see therapeutic intervention. This chart Dr. Shubhra also explained very nicely. So there are certain foods which can cause relaxation of the lower esophageal sphincter, and that may cause more reflux. Like tea, coffee, high fat foods, they can cause more reflux. Carbonated drinks and spicy foods, and avoiding foods within 3 hours of bedtime. If you take dinner late, then there are more chances you will lie down after take. हम लोग कहते हैं कि खाना खाने और सोने के बीच में 2 घंटे का फर्क होना चाहिए. That is because if you will take late, then you will lie down and then all the GIT movements will be slow and the food will be staying in your stomach for a longer time, and there are more chances of reflux. So small and more frequent meals with reduced fat content. This is a very important thing. If you are not, you should eat till you are 80% full. That's all. जब बेल्चिंग हो जाए, खूब पेट भर गया, अच्छा लगा और खाएंगे, तो उसके बाद तो फिर आपको पेट का प्रॉब्लम होना ही है. So you have to be very careful what you are eating, how much, what portion size you are eating. And weight loss for the patients who are overweight or obese, this is very important. Obesity, diabetes, obesity, heart disease. Obesity is the janani of all the diseases today, whether it is a heart disease, diabetes, cancer. Avoidance and reduction of alcohol, smoking, they are associated with all the diseases. Head end of the bed should be raised in those patients who have early morning symptoms or late night symptoms, or who take dinner late. Regular exercises, that is the advice to all our patients, whether they are obese, whether they are lean, whatever is this, lifestyle has to be good. Now, heartburn no more. Treatment strategies. What are the treatment strategies? If there are alarm symptoms, which I told you, dysphagia or dynophagia, weight loss, GI bleed, anemia, and Barrett's esophagus risk factor. What is Barrett's? Actually, once normally there is a squamous epithelium in the lower esophagus, and it is not meant for acid. And if there is a constant acid, then it becomes a metadysplastic columnar epithelium. It becomes the epithelium like in the intestines. It is the esophagus becomes like intestine. So that is why these patients have gradual damage to the esophagus mucosa, and this can be diagnosed by a endoscopy. Simply endoscopy, color of the mucosa will tell, and then otherwise also they can do a biopsy and decide what type of the problem they have. Now GERD with another risk factor, more than 50 years old. But friends, it is important that GERD and Barrett's esophagus are occasionally related to each other. They are definitely related, but the incidence of Barrett's is very low, very low. And in the Barrett's, the incidence of carcinoma is also low. So it is not just to say भाई इसकी वजह से ये ऐसा हो जाएगा, लेकिन होने की possibility बहुत कम है. पर those who have it, they can be. It is a preventable disease by a timely stitching time can save 9. Now alarm symptoms, we have told you endoscopic evaluation, that is very important if the patient is having alarm symptoms. How to treat these patients? Objective signs of acid reflux, you have to see LA grade, which I told you, LA grade BCD esophagitis. So this is endoscopic evaluation of the esophageal mucosa in the patients of GERD. You see whether there is a small ulcer less than 5 mm, more than 5 mm, it is all around or occupying 75%. So depending upon the grade, you can diagnose what is the stage of the damage done to your esophagus. And if there are objective signs or no objective signs, depending upon that, you have the medical treatment and regular follow-up. Regular follow-up is very important, and follow-up may be by clinical follow-up and endoscopic evaluation. If there had been a first endoscopy is positive, then you have to definitely do a second endoscopy to see what is the effect, so that you can decide what will be the line of action. Now, comprehensive treatment strategy for functional dyspepsia. You see, these are the patients who need a good lifestyle support, good family support. Lifestyle advice is a cornerstone of management of these patients for whoever don't have an organic problem. And they can be managed very well in the primary care, and especially if they have some risk factors and more risk factors, if they are evaluated once endoscopy is normal, then they have a full reassurance that the doctor has seen and the endoscopy is also normal, then they can be managed properly with a proper treatment. We have good antacid treatment available, whether it is a liquid antacids or PPIs or H2 receptor blockers or even vonoprazole, which is very important these days because they are very quick acting and most powerful. It is 300 times, more than 300 times potent than omeprazole. So we have such good medicines available, we should be using them in more number of our patients. Helicobacter treatment, that is very important, and in this slide what I could see that if we are giving 2 antibiotics with PPI in double dose, why PPI is in all those patients is given in such a heavy dose? Those patients who are being treated for Helicobacter, why PPI is in such a heavy dose? So then the reason is once you suppress the acid to the fullest, the antibiotics become more effective in eradication of the H. pylori. So this is very H. pylori start multiplying only once there is less of the acid. So antibiotics become more effective. So for full eradication, full acid suppression is very important. That is why vonoprazole, which is a very quick acting and very effective suppressant, may be a good combination later on in combination with the dual antibiotic treatment. About antacids, Dr. Shubhra has told us well, with anesthetic agents also. So this adds to the management of the patient, especially early control of the symptomatic patients. It is a integrated patient. Patient has to be looked after as an individual, and single patient directed therapy is very important rather than management of a disease. It is the management of a individual patient, clinician and patient. So you have to give some time and for management of this type of the patients, evaluation. Polypharmacy is very important because we are taking so many medicines at a time. People are taking medicine and they are taking medicine for everything, but they don't know what the benefits of the medicines are there. The physical activity and the good patient care and guidance, that is very important. लास्ट स्लाइड तो दिखाने के पहले वो भी रुक गया, इसके बाद सिर्फ लास्ट स्लाइड नहीं चलता अभी. कोई बात नहीं, लास्ट लाइन में समराइजिंग है, we summarize that whatever we give to the patient has to be in the interest of the patient with a proper advice that PPIs, see initially H2 receptor blockers were there, उससे ज़्यादा पावरफुल आया PPI, उसके बाद आया है ये जो आपका वोनापराजोन है. So these all things are available to the patient and they should be judiciously used. PPI is given for a long time, side effects are not many, but whatever are reported, there some people have nausea, some people have constipation, some people may have B12 or iron deficiency, and those patients who have acute interstitial nephritis, these are the sort of the side effects, or hypomagnesemia, these are the serious side effects which may happen in once in a blue moon type of patient, but unnecessary taking medication should be avoided. So thank you very much.
Thank you so much, sir. Ladies and gentlemen, please once again give a huge round of applause to our eminent speaker, Dr. A.C. Agrawal sir, who has done complete justice enlightening us on such an important topic. And now it is time for question and answers. May I request our learned chairpersons, respected Dr. Mayank Malhotra, Dr. Puneet Puri, along with our eminent speakers, Dr. Shubhra and Dr. A.C. Agrawal, to please take their respective seats on the dais. And now the house is open for question and answer sessions.
मैम ये बताइए कि हर प्रिस्क्रिप्शन में हमने देखा 90% प्रिस्क्रिप्शंस में जो है ये आपकी पीपीआई लिखे जाते हैं और लंबे समय तक चलते हैं. अगर उसी पेशेंट को अगर बताया जाए कि मेडिसिन खाने के बाद दीजिए, एक सिंगल मेडिसिन के साथ भी पीपीआई लिख देते हैं, क्यों लिखते हैं और कैसा, मतलब इसका क्या इंडिकेशन है, क्या
नहीं सर, मतलब यू आर राइट कि अननेसेसरी पीपीआई जो है
90% प्रिस्क्रिप्शन में देखा पीपीआई सिंगल मेडिसिन के साथ.
First of all, we need to decide whether we want to suppress the acid or what we are treating. First, we need to know that. If we need to suppress the acid, there are particular indications like Barrett's esophagus, severe esophagitis. Patients already had CAD and have already encountered GI bleed in the past. So these are few indications. Patients who are treated for ulcer disease, these are the particular patients who need acid suppression. Another subset of patients are also there that only need prokinetics. For GRD. And here also there are certain implications. The most common cause of GRD in India is binge eating disorder. Whenever you sit in your OPD, you ask the history of the patient. Most of the 80% of the dyspepsia and GRD patients have binge eating disorder. We never mention in our prescriptions. I usually mention sometimes when we have less number of patients, but it's most of the time binge eating disorder. They eat 4 chapatis at a time, 8 chapatis at a time. They don't have even insight what they are eating. And we in our busy OPDs just write spontaneously. It's always given Pentosid DSR and whatever DSR is all given. So we are the persons who have to decide what we are treating. One, we have to treat the patient only with prokinetics or antacids, or we need to suppress the acid. For acid suppression, Dr. Shubhra has already mentioned what are the indications for acid suppression. So these are the two aspects: acid suppression and where we need to control the symptoms with prokinetics. What is your take?
Dr. Mayank has rightly said. The problem with GERD is gastroesophageal reflux disease. The problem lies in the lower esophageal sphincter. There is a problem that acid is coming back. If we look at the etiology of this GERD, she has rightly mentioned there are relaxation of the lower esophageal sphincter which happens for a pretty longer time. Or there is a hypotonia of the lower esophageal sphincter. Sometimes there is a problem with motility, that whatever acid has come into the esophagus, that is not being cleared properly. But nowhere it is written hypersecretion of the acid is cause of GERD, isn't it? But the entire pharma is focusing on reduction of acid, whether it is PPI, H2 receptor blocker or PCABs. So my question is, and concern is, if the fault is in the sphincter, then why we are bothering to suppress the acid altogether? So here lies, most of the patients with GERD, Even the American Gastroenterology Association and even Indian ISG Society also say if we have occasional symptoms of GID, first step is to occasional symptom of GID, we should give PPI first. If the patient is relieved, then no need of further testing. Fine, to an extent. But there is a term called refractory GERD, which does not get relieved with any of the therapy, whether you take H2 blockers or PPI or their combination. 30% of the patients, they have refractory symptoms, which are well documented on endoscopic evaluation also, that there is persistent esophagitis. And this subset is not less. 30% is a significant amount. These are the patients who need further testing in the form of pH impedance manometry. Because reflux is not only for acid, it is for non-acidic contents also. Food can also come. We see daily in our OPDs patients saying that my food is coming through my nose. Bile is also coming out. So these are the two things which are non-acidic reflux is also very common problem. And pH impedance manometry, plus it should be combined with HRM, high resolution manometry. Because motility disorders are also a part and parcel of our other problems of the GIT. And they don't lie alone. Even if you don't ask for a manometry, you will never come to know that a patient is suffering from a motility disorder. I am a GI surgeon. I treat these patients who are not responding to medical therapy, or who have suboptimal responses, or who are dependent. Moment they stop drug, their symptoms they come back. Now, sir and Dr. Shubhra has rightly mentioned, as the age is progressing, the motility is reducing, and our subcontinent is suffering from a very big problem, that is diabesity. Not only obesity, but along with there is a diabetes, and it has a profound impact on the GI motility. Delayed gastric emptying is no more a problem of West. Indian people are suffering more and more with this problem. So delayed gastric emptying, even esophageal motility is being hampered. Second issue is not only with the advancing age, even the younger children, because of our cultural change, they don't go outside for their plays. They are sitting in their house with home theaters and eating high calorie food and watching movies. That is their pastime. So the obesity problem is rising very, very fast in children also. So I have operated on a youngest patient of 13 years of age. I have done fundoplication for refractory GERD. This is my personal experience. That child was not getting relief from any of the medications. Persistent vomiting and acid reflux, which is documented on pH manometry. So this is the stance in present era, that it is not only the age, even the younger population is also getting affected. And as sir you have rightly said, PPIs are available over the counter drugs. So is true for NSAIDs. As the age is advancing, many patients are suffering from osteoarthritis, knee pains, spine pains. So they are habitual to taking NSAIDs over the counter without any prescription. And once in a month, I used to get a patient who has peptic perforation because of uncontrolled, unsupervised use of NSAIDs. So these are the things which we face in our Indian setup. Yes, a doctor can prescribe a medication, but there is no capping on stopping the medication. That's I wanted to tell.
I think besides anesthetics, the steroids also.
Yes, steroids
so frequently and for years together.
Yes.
For asthma and all that.
Right.
Once they know it acts, gives relief, they start taking from the counter.
Absolutely.
Like sir, if you notice something, which at least I have noticed in my OPD, what patients require more than PPI is the prokinetic. Like if there is a patient and you prescribe them Sompras DSR, Thymosin DSR, and on the second visit you prescribe only Sompras, they will not be happy. They will say that no, you have not given me the capsule which I need. So it's actually the bloating and the impaired GI motility which is causing more problem than the acid secretion itself. So many patients they just require prokinetic rather than PPI. Secondly, patient education. We have to tell them that normal gastric emptying is 2 hours. It is okay to feel some discomfort post meals, and it's better to go for a walk rather than taking PPIs indiscriminately. So our patients are not educated well, they are not aware, they want an instant relief. which leads to this rampant use of PPI and prokinetics.
The most important thing is that the prokinetic agents should be used judiciously, because something like etoposide or levosulfuride or ecosiamide, these are being used in many number of patients, but they cause certain side effects. Even domperidone, DSR used for 4 months together, there is hyperprolactinemia and gynecomastia, and there are many symptomatic patients who are having these type of problems. So we have to look after कि जो लीवोसल्फराइड जैसे आप एल्डरली पेशेंट को 60 से ऊपर दोगे, अगर उनको फिर न्यूरोलॉजिकल डैमेज हो गया तो इवन फ्यू डोजेस कैन कॉज परमानेंट प्रॉब्लम इन विच दे हैव ट्रेमर्स एंड डिस्टोनियास. So you have to see what you are prescribing for how long, and with the safety profile definitely kept in mind.
So sometimes we see as a complication of GRD, esophageal stricture response. So when would you like to operate, or would you like to treat the patient conservatively, and how long the patient can be treated?
These are the patients who have refractory GERD. When their inflammation is not improved with medical management, so there is fibrosis which leads to stricture formation. So as I rightly said, a refractory GERD patient should be referred to a specialist for proper evaluation. These peptic strictures are totally preventable strictures if we offer a adequate treatment in time. And what is adequate treatment? Fundoplication. So once the stricture has already set in, yes, to begin with we can offer an endotherapy with the help of dilatation. Balloon dilatation can be offered. If 2 or more sessions of endotherapy are needed, probably that patient actually requires surgery in the form of a esophageal resection and replacement.
And sometimes a patient goes on to the Barrett's esophagus. Then how can you prevent that? Would you continue with this prokinetic and this PPIs? Will it help in that case?
Double dose PPI, and for lifetime. And you need to biopsy the patient every year. If patient has dysplasia, high grade dysplasia, then the patient needs to go for surgery or some sort of endotherapies that are evolving. Also for peptic structure, we follow a protocol of 5 dilatations. 5 dilatations, 10 to 14, 20 to 14 days apart. If patient is not responding, because that need to be done gradually. Like we dilate with 10 mm, then 12 mm, 13 mm, like that we dilate. So it's not so that we dilate it up to 17 mm per go. It can lead to esophageal perforation. So we need 4 to 5 dilatations before commenting on that it is failed endotherapy. But most of the patients respond to endotherapy well, and with PPI that is given with dilatation. So patients are referred for surgery only when endotherapy fails. In the present.
Another issue is regarding hiatus hernia. Now on endoscopy, we usually say out of 10, 2 or 3 endoscopic reports must be telling there is a hiatus hernia. Sometimes it is written small, sometimes it is graded according to Hill's classification. So the world literature is very clear. If there is a small hiatus hernia of 2 cm or less, it can very well be treated with lifestyle modifications and drugs. But a hiatus hernia of size more than 2 cm, 3 cm, 5 cm, these are the patients who should not be unnecessarily offered medical management because their physiology is altered. Their gastroesophageal junction has already migrated into the thorax, which is a negative pressure cavity. So the reflux can never be solved without restoring their anatomy and physiology. So these are the subset of the patients. If you find a hiatus hernia 3 cm size or more, direct, straightforward surgical intervention.
Give at least 14 days of therapy to patients with large hiatus hernia. You will know whether patient is responding or not. Because surgeons also prefer patients who are not psychological.
Yes,
Many times
yes.
you land up with mess because they operate and then they keep on coming to you, sir, I am not leaving. I am not leaving even after large hiatus hernia surgery.
Basic
So,
principle for surgery is choose well, cut well, and you will get well.
And we choose well because as physicians we usually get large hiatus hernia. And what I recommend, take the medicine for 14 to 15 days, PPI. If you are completely relieved, now you are better, yes, stop the PPI, now go for surgery. You are the right candidate for surgery also. Because giving PPI for lifelong is not right.
Any PPI or some specific PPI is preferred, like Rabi or Penta? Which one do you prefer?
No, you can prefer anyone.
There are few studies which were telling that esomeprazole is better.
Yes.
Better.
But-
Esomeprazole is better and always potency is better.
And reviprazole doesn't get metabolized by cytochrome, this CYP pathways, because there are interactions. And Indian population have heterogeneity of genetic makeup. So some people are extensive metabolizers. So reviprazole is considered better drug in those extensive metabolizers.
आपने समझा कि हाइपोथर्मिया जो है अगर कम हो तो एक्सरसाइज से ठीक हो सकती है वो कैसे?
सर एक्सरसाइज से ठीक नहीं हो सकती, एक्सरसाइज से उसके सिम्टम्स कम हो सकते हैं लाइफस्टाइल मॉडिफिकेशन से। लाइफस्टाइल मॉडिफिकेशन मींस यू शुड नॉट हैव बिंज ईटिंग, दैट इज वेरी वेरी इंपॉर्टेंट। पूरे दिन का खाना एक ही बार में खाना जरूरी नहीं, सो दैट बिकॉज देयर इज अ प्रॉब्लम, इट इज रिलेटेड विद फिजियोलॉजी। व्हेनेवर द स्टमक डिस्टेंड्स द गैस्ट्रोफ्रेनिक लिगामेंट जो स्टमक से डायफ्राम के साथ जुड़ रहा है, देयर इज अ स्ट्रेचिंग ऑफ दैट, and whenever there is stretching there is a probability of reflux. So जितना ज्यादा आप उसको स्टमक को ओवर स्ट्रेच करेंगे उतना रिफ्लक्स की probability बढ़ जाएगी।
Respected
So
Dr.
hernia patients who have severe esophagitis, they also need surgery. Not it's all of them. Not there is nothing like that. Small hiatus hernia patients who have severe esophagitis, they need surgery.
Just want to know which is the safest prokinetic and which prokinetic has a lower GI effect.
Dr. Shubhra.
Sir, safest prokinetic would be etopride right now as compared to domperidone and lisinopril. If we are talking about your CNS side effects.
Overall.
Also. And lower GI effect, procalcitonin. It has effect on both lower GI motility and upper GI motility.
Ecotimide. Which one?
Procalcitonin. Procalcitonin, sir.
So this is basically for lower GI.
But it effects on the upper GI motility as well. Although it is being marketed as only for constipation, but it has a pan GI effect. So actually it increases gastric motility also. Both.
In a patient of diabetic gastroparesis, etopride, how long should it be continued?
Sir, now for diabetic gastroparesis, so your ultimate management will be diabetes control, which might lead to some reversal of gastroparesis, improvement in motility. So there is actually no cutoff of how long you can give. Totally depends on your symptom control.
Nowadays it is a rising concern because the younger people are suffering from GIRD. The question is for how long will you prescribe PPI? Lifelong is the answer or no? Youngsters, they don't want to take medication, so compliance is also a question.
So in the patients of CKD, as Shubhra said, that there is a PPIs are contraindicated. So like many times we have patient and we have to give short-term steroids along with that PPI are to be given. So can we give it short-term, or there is any cutoff level of serum creatinine or urea or anything on the basis of which we can decide, or we should entirely not give it and we should go to some other?
All the PPIs can be safely prescribed to the patient with renal failure because these PPIs are metabolized through the hepatic route.
Okay.
And even the thing which is like gonaprazole, which is excreted 33% through kidney route, it's metabolized. It is a non-active form of which is excreted in the urine. So those patients who are on PPIs for long time, if they are showing signs of renal involvement, they are showing active urinary sediment, or they are having loss of appetite, they are having some swelling, then you have an evaluation of the renal function. And if the earlier renal function was normal, then you can think of this problem because it is an acute interstitial nephritis which is caused by some patients with the PPIs. So it is not all those renal problems. Even in renal problems, you can give 2 weeks. You should know why you want to give PPI. And if the PPI is required, then 2 weeks safely you can give PPIs without any problem.
Sometimes we have to give steroids in some of the patients, then we can add for short-term.
Any questions? Any more? So I think the topic has been judiciously discussed. Ladies and gentlemen, please give a huge round of applause to our eminent speakers and learned chairpersons. With this, we bring to the end of question and answer session. May I now have the honor to invite Dr. Shalini Mohan Ma'am, Honorary Secretary, IIMA Kanpur Branch, to kindly give vote of thanks.
करा देते हैं. because इस समय केवल photos हैं.
ठीक.
So I'm so thankful to speakers, respected Dr. A.C. Agarwal sir, dear Shubhra, for wonderful topic and making it so simple that we all could understand it nicely. And of course, both the chairpersons, Dr. Mahindra and Dr. Mehrotra and Dr. Puri. So both of them discussed it so well. I'm so thankful to all of you. Now we would like to extend our heartfelt gratitude. I would request President Dr. Anurag Mehrotra to kindly come up. And I would request Dr. A.C. Agrawal sir to kindly accept a memento. And I would also request Dr. A.K. Srivastava sir, past president and very respected of IMA, to join us on the dais for presentation of memento.